going to present today a little bit about cognitive rehabilitation. The main reason was that we often tend to leave these things as either undoable or we say there's not enough evidence for it. And so it gets left behind. But actually, it has a huge impact on people. And probably it's the starting point for which every other bit of rehabilitation of the brain is based on. So it's actually quite an important area of practice. And unfortunately, there's not that much evidence for it. And so we tend to wonder how to start. So what I'm going to do today is just start off with first looking at the acute settings in which you need to think about cognitive rehab, and then look at how to look at the more long-term aspects of cognitive rehab. So the first thing is, in an acute phase when somebody comes to you, it's quite often, you'll see quite often in the general wards that everything is called delirium. And it may not be so. In fact, very often, especially in stroke settings or traumatic brain injury settings, or people with sudden acute neurological presentations, it may not be that. The obvious first thing to do, and everybody would have told you this before, is to make sure they have their spectacles and their hearing aids and their dentures. And in a population, our hospitals are increasingly having more and more older folk, and so this really becomes important. The second thing to look at is to see whether they have had any problems with their cognition beforehand. Because very often we find somebody comes in and they say, oh, this person has developed a very severe difficulty, and actually speaking, this person's been living with it for a long time at home, unrecognized. And the third thing to look at is as soon as people come into hospital, they're given a whole lot of medications. I still remember getting a patient from ITU, and they told me this person has got very, very severe brain injury. In fact, may not survive a day, but there is nothing more we can do for him. So because we had a bed, we said, okay, let's take this chap. Came in, they put him on a palliative care pathway, took away all his medications. By the next day, we had to restrain him because he was so agitated, restless, but otherwise perfectly, strong and healthy. And the only thing that had been holding him back was the fact that he had been given a whole load of medications. And with the reduced neurochemical thresholds in the brain, he was completely flattened by them. And the last thing to remember when you're assessing these people in an acute setting is if you go to them after they've not had a good night's rest, or if they're in a 6-bedded bay and the neighboring patients have been shouting all night, you're not going to get much out of them in the morning. So make sure that they are not fatigued when you're examining them. But these are the common things that can distract and deceive you when you are trying to plan out a cognitive rehab program. So remember, fatigue is the commonest reason for a delirium mimic, which hides the fact that they've actually got some cognitive changes. The second major cause of a delirium mimic is still fatigue, and the third is still fatigue. So you really need to pay attention to fatigue. Anyway, but the other causes are cognitive causes of difficulty are when people have things like Charles Bonnet syndrome, and they start to see things and you think, oh, this is psychosis. Or when they suddenly start to yell and shout and you think, oh, they're getting worse, but it's actually just episodic dyscontrol, and all you need to do is find out what triggered it, avoid those triggers, and the behavior settles. Or if people are either depressed or coming to terms with their disability, and they go very quiet, very non-compliant, and you think, oh, they can't understand, or they're abulic, or something else. It may be just a psychological problem, or just plain depressed mood. And they may need a pep talk. They may need to be told how to learn to deal with their suddenly acquired disability. The next area before I move on to long-term cognitive rehab is to make sure that wherever you're working, you have a good link with your emergency department, your A&E or your casualty, and make sure that they don't send away all people with mild traumatic brain injuries, because more than even last week, I had a patient who they didn't send from A&E. Person goes home, because they just have a minor, maybe half an hour post-traumatic amnesia period, a bit of a headache, a bit of concussion, and nothing to show after that. They send them home, and then the patient's life falls apart. Their family breaks up because they badly behaved. Their work removes them from work because they're not able to cope at work, and they don't know why. And very often, just telling them the first 3 months after a mild traumatic brain injury is going to be difficult. Forewarn your family, forewarn your co-workers about episodic dyscontrol. Make sure you know that you can't just take a centrally acting medication without it really affecting you very badly. Make sure that they're warned about alcohol, because their neurochemical thresholds reduce to alcohol as well. And so a little bit of alcohol may predispose them to seizure risk, may predispose them to episodic dyscontrol, and may work much stronger than they previously knew about. Forewarn them about dizziness, and tell them that things will improve with time. And if they don't, there are rehab strategies, and make sure that they are, in my case, I have a charity. We have a charity in Scotland which offers peer support to people with mild traumatic brain injuries. So make sure they have the contact, and that they have a way back in. So I follow a patient-initiated return method where they can call in and ask for help if they need it, and they can get an appointment if so. Right, so let's move then on to cognitive rehab and how to assess. So the first way to look at cognitive rehabilitation is to think of it based on the lobes of the brain. So if you go by what you're seeing there, on the left side, the parietotemporal areas, you can expect to see aphasia, expect to see alexia agraphia. If you move to the left frontal lobe, you can expect to see a lack of drive. Right frontal lobe, you can expect to see perseveration. Right parietotemporal, you can expect to see neglect, visuospatial difficulties. In the right occipital, you can expect to see an inability to recognize faces. And in the left occipital lobe, you can expect difficulties with color and object recognition. There's also now, in the last 4 or 5 years, a recognition that people with newly developed, like strokes or traumatic brain injuries, can also not be able to recognize emotions. So, for instance, that's a picture of what the patient probably sees and can't make out what the person or what emotion the person they're talking to has. And this, interestingly, is most prominent for negative emotions. So they'll know when people are happy, but not know when people are angry or sad. And in our modern day world where we use a lot of emojis in our communication, they may not be able to make out the difference between emojis. Now, interestingly, when they've looked at this recently, that's not based on lobe function. That's a picture of what happens in the brain in terms of messages going back and forth through the white matter to various parts of the gray for a person to recognize emotions. And so you can straight away see that the right-left pattern that I just talked about, the lobar definitions of function that I just talked about, may actually not be entirely true. It's useful to understand, but you have to be aware that it may not be true. I still remember Professor Bhattacharjee used to tell us, the patient doesn't read the textbook. Right, so the other way to look at it is obviously arteries that supply the brain, and there again, the middle cerebral artery obviously being the most common artery affected in stroke, you can expect the right side to give you neglect and apraxias, the left side to give you aphasias. And I won't go through this in great detail because it's largely the same as what I just described, but every artery has a presentation, and you can basically, if you know which, whether it's an anterior circulation stroke or a posterior circulation stroke, you can expect a set of cognitive difficulties. But just to forewarn you, if you see a normal scan, that doesn't mean that a person will not have cognitive difficulties, because ranging from mild to severe traumatic brain injury, for instance, as an example, you can have a lot of things that happen within the structures of the brain at a microscopic level, which you cannot see on the best MRI scan. And this is this next slide is is the last way in which I look at cognitive rehabilitation, and probably the most useful way. That is to think about it as a hierarchy. So at the bottom of the hierarchy, the first thing you have to make sure your patient has is the ability to keep awake. The next level is to look at whether they can pay attention to things, whether they're oriented to things, whether they can remember things, whether they can understand things properly when they see it, and whether they can make decisions from them, and whether they can communicate it. So those are the next sort of the basic building blocks of cognitive function. And then comes the next hierarchical step is executive function. That is the ability to put things together from the second step and make a decision and plan of action. And the last one is metacognition, which is an awareness of what you should, of what you have lost. Now, of the four, it's very interesting. Well, let's take the top three steps. One would think that, I do want my memory back. And that's what patients will always tell you. I've lost my memory. I do want my ability to speak. But interestingly, if you look at their lives longer term, it's the people with preserved metacognition, irrespective of how bad their attention, orientation, and executive function are, it's the people with preserved metacognitive function that do the best. So, for instance, I had a person who could not, when they heard a number, they could not. And their job used to be working in a big firm. They were responsible for ordering items before the stock ran out in the go down. And you can imagine what difficulty they would have going back to work if they could not understand the number that they heard. But if they saw it with their eyes, they could understand it. So this lady actually went back to work by doing only one thing, and that is saying, I'm going back to work, but I will not have a phone in my office. Everything has to be sent to me by email. And the person was offered many times, offered promotions to a manager's job without improving. She still had the same problem. She wisely turned it down because it meant that she would have to go into an office with a phone. That would have been the end of her job, So metacognition, of being aware that you don't have something, is the best of the lot of things when it comes to that approach. So then how do you assess all that? I'll just go back there and say that here, I'll just show you the slides of these assessments, but the best thing to do for you, if you haven't done them already, is to just get a partner and administer it to each other. That's how I learned years and years ago how to administer these tests. So that's the Addenbrooke's cognitive examination, and I'll talk to you about the new one, the Oxford Cognitive Screen. This is the multiple errands test, and I'll show you the forms that you can use for each of these steps. And the reason why I like these are because each assessment component of these tests allows you to plan a specific cognitive process. So looking at the behavior, the other assessment that's really helpful as a start is antecedent behavior consequence, the ABC charting, and you're probably aware of this. And this is a slide from when I used to work in Vellore, where we used it to look at a patient's behavior to try and find out whether there was something that was triggering their behavior. And then you sort of analyze it and then realize, oh yes, there's something that triggers this behavior, let's avoid it. The same with the sleep. If you have a person who's not sleeping properly, then you again will have problems with their ability. I told you about fatigue when I started off. Their ability to participate in rehabilitation in the daytime. And so a sleep log is a useful thing. So rather than, this also helps the nurses to realize that when they have a patient with fatigue, they shouldn't go and wake them up in the middle of the night to give them a tablet. And the way to remind them is to have a sleep log, because they actually have to document whether the person is awake or asleep. And so they suddenly realize, oh, this hospital inpatient's sleep at night is actually very important for his daytime rehabilitation. And these are a set of 3 pages for the Addenbrooke's cognitive examination. But basically what you have to remember, if you haven't already done this, is that it assesses attention. So here you ask them to give you letters beginning with words with letters beginning with P, and animals, as many animals as they can. And it's taken as fluency, but you can take it as a surrogate for executive function. So that's the advantage of the fluency component. And you have language components, visuospatial components, and memory components. And then you get to sub-score, which helps you to plan which thing you need to really pay attention to. So it's a very helpful cognitive examination. It's transdisciplinary, so anybody in your team can use it as an assessment. And there's some versions of it which are freely available, so you don't need copyright. And this is the other one, which has recently been developed mainly because if somebody has a problem with communication, then a lot of the Addenbrookes test, you get a falsely low score. So the Oxford team tried to sort that out by using the Oxford cognitive screen, which sort of gets around that. And again, similarly, you have sub-scores from various things. And this one, again, if you write to them, they usually allow you to use it. So there's not a major copyright issue. And the really good thing is you can administer it over a video screen. So if people can't come to you, you can still administer it. And the third nice thing about it is there are video training there are training videos where you can actually learn how to administer this, and it comes with a score sheet and everything else. So if you just search for it, you'll be able to get it. The next one is how to assess executive function, and we used to use in CMC Vellore the multiple errands test, which was a bit clunky, but we used to do it once a person was ready to go home and probably just before they were going to consider returning to work. So it requires a whole set of tasks to be done, and it requires the tasks to be assessed. Now, it was quite difficult, and we had a major arterial road just outside Rehab Institute in Vellore, for those of you who have not been there. But so it was dangerous because this one required you to cross a road and buy something. And again, the Oxford team who designed the OCS have now got an app which you can download and use it to administer the test to patients. Okay, so that's all the assessments that are useful, which translate directly into what you can do. Now, the problem is that, as I told you, there's a lack of evidence. And the way which most people have done till recently was to say there's lack of evidence, so we can't really do anything about it and leave it at that. And the occupational therapists and the psychologists used to try and do what they could with what they've got. And we as PMR doctors used to say, oh, let's try this and let's try that on a very ad hoc basis. So what the ACRM did recently, and they have a cognitive rehabilitation task force, which I gather meet every Monday on some sort of social media or video conferencing meeting. But they got together and in 2019 devised a set of practice standards, practice guidelines, and practice options. So 3 levels of evidence, and I've only put the standards out here because even the standards are based on, obviously because we don't have enough research, based on insufficiently good research. So they have 5 major areas: attention, left visual perception, mild procedural memory, communication and social function, and mild to moderate executive function. These are the areas that they have evidence for good standards. But you can see I've bolded what is important. So it's using strategies that forms the basis of cognitive rehab. You're not going to be able to give them a tablet or give them a machine or something. You have to teach them strategies. You have to teach the family strategies to support them or the carers. And we can use technology to help with reminding people of strategies. And the technology bit is becoming really important because all of us now use phones anywhere in the world, whatever the socioeconomic status. And so it becomes quite easy to get this little device to remind you to do things, to provide you with auditory cues and a whole lot of abilities. And people can develop apps, as I just talked about, to provide that sort of information. Right, so strategies are the first thing. Internal, teaching people to use a thought process like imagery or association, or external, as I talked to you about the mobile phones. to focus on functional abilities. Don't look at, this whatever lesion has become smaller, or bigger, or therefore the prognosis is bad. No, look at the way they use their function, because remember that lesion may not be the pivot on which your function rests, because of that other graph, the scan I showed you, the fMRI scan, where things are crisscrossing across the brain, and therefore go with function and go with client-centered goal management. Those are the sort of key things that will help you to move your cognitive rehabilitation forwards for a patient. You need a lot of time to deal with it. I usually give each person an hour, and unfortunately for us, we don't have good support from psychology and occupational therapy in the community. In the inpatient setting, we have some occupational therapy support, but you'll invariably find that unless you have a team who are very keen on cognitive rehab, because of the fact that there's not much evidence, and because it's a difficult thing to deal with, you'll find that most people will be more willing to get people to walk and become independent in their ADL than they are to improve their cognition. Right, let's move on to a few more specifics. You know about the field deficits in stroke or in any lesion, and usually it's that we have to deal with most. But also you have to deal with hemi-neglect. As I showed you in the first set of graphs, there's a lot of neglect issues. And sometimes both happen together. Sometimes you mistake hemi-neglect for hemianopia. All these things happen all the time. But it's important, whether it's hemi-neglect or hemianopia, for us to pick it up and tell patients about it. And you'll be surprised at the number of people who are missed. And so it's really important to just both fingers out. You don't actually need to tell them to cover their and cover one eye at a time. When you're screening, when you're testing, obviously you need to, but when you're screening, you don't need to, because if you just put your two fingers out, wiggle one, and they point to it, you know that field is okay. There's no homonymous hemianopia. Wiggle the other finger, and you know that the other field on the other side feels there is no homonymous hemianopia. And then wiggle both together, and if they can see both going together, you know they have no hemi-neglect. So there's an easy screening tool to differentiate between hemianopias and hemi-neglect and pick up both. But obviously, if you don't do this, you'll be surprised, as I said, of the number of people who've come through A&E, they've gone to ICU, they've had their thrombolysis, they've had acute rehabilitation, and it's still been missed. So it's a very simple thing. Takes you less than a few seconds to do, but it's really important. Because if you miss that, then you actually are going to run into a lot of trouble. The other thing to just remember is that there is a new way of, I say new, it's about 20 years old, of understanding the way in which we process visual information. So here's somebody seeing a cricket ball coming at them. Their occipital lobes will obviously tell them, yes, this is a spherical red object. Then you have two streams. You have the ventral stream, which identifies it and tells you, oh, it's a cricket ball. And then there's the important dorsal stream, which tells you, gosh, it's moving at me at great speed. I better either catch it or duck. So that's the way in which we process visual information. And it's important to remember this because you can identify problems with the ventral stream and devise ways to get around it. Identify problems with the dorsal stream and devise ways around it. So how do you do that? There's a little set of questions, and these are all going to be available. Dr. Venugopal tells me is going to be available on YouTube, so don't bother, going through all the details. But please make sure that when you're using this questionnaire, that you acknowledge Dr. Gordon Dutton, who is a senior pediatric neuro-ophthalmologist who's an expert and written a textbook and just gave this to me to use for my personal use. So remember that it's a guidance and always acknowledge Professor Dutton. But if you have a set of questions that you ask them, it'll tell you, depending on whether it's yes, no, whether you're dealing with agnosias, visually guided movements, field effects, simultagnosia, which is difficulty recognizing two things at the same time, visual attention difficulties, motion perception difficulties, hallucinations, and blind sight. Blind sight is the ability to see things in the hemianopic field. And then for each of those, there is a corresponding document which gives you the strategies that you can tell your patients about. So again, I'm not going to do this because of lack of time, but you can go through it at your convenience. The other thing to remember is that sometimes with visual difficulties, you'll see children who come to you like that, and you might want to give them botulinum toxin into their necks. But remember sometimes that a head position is because they are actually trying to get their vision organized. And so not all, and conversely, if somebody has difficulty with a field deficit or double vision, you can actually use head positions to sort their vision out. And so there may be simple ways in which to sort their vision out, and it's important to remember not to discount that. Every time somebody can't communicate, it may not be a language problem all the time. As these pictures show you, it may be the fact that they can't recognize what they're hearing or recognize what they're seeing, and be aware of that. And if you're aware of that, then if somebody can't read, then it may not be just a matter of teaching them how to read. I had a patient, this is their scan, who couldn't read, and I suddenly realized that this person could write and this person could copy. So as I was testing to see whether they could write and copy, the sentence which they couldn't understand when they read, they suddenly understood as they copied it. And so I suddenly realized here's an easy way to get the person to understand what they're reading, is to just, they may actually have to write it on paper, but even if they trace it out with their fingers as they're writing, as in write out what they're reading with their fingers, and nobody needs to see it. You can have it under your desk and be just writing what you read. You'll actually understand it because you're sending the messages through a different pathway. So think of unusual ways to get around problems, but the only way you can do that is if you remember that language is not always the reason why you can't understand. Similarly, when people can't move, it's not always strengthening that's a problem. Remember the dorsal pathway and try and find a way around the dorsal pathways. It may not just be a matter of improving voluntary control, but getting the brain to recognize where the coordination is. And finally, with dyspraxias, make sure that they understand it, because if they understand it, then they'll be able to plan things out. If they know that they can do individual things and can't put it together, then suddenly their frustration reduces. And when you tell them to break it up into small subtasks, their ability to complete the big task improves. But it's teaching them and talking to them about it, and that doesn't take very long to explain dyspraxia to people. Similarly, with episodic dyscontrol, explain to them that they may suddenly lose their temper or burst into tears without actually even feeling anything, and that's something that they just need to get used to. It'll subside with time. There may be an antecedent to avoid it, and please tell their family and co-workers that this happens. And finally, as I said, for mild traumatic brain injury, you need to remember that they need to be aware of all the things I've talked to you about with either booklets or, as I pointed out, charities and things, because that's one easy low-lying fruit. If you make sure that all those patients with mild traumatic brain injury just get maybe half an hour, 1 hour with you, you'll be able to tell them, forewarn them, and on their way they go. And hopefully they'll improve in a few months' time. But they won't lose their families, lose their jobs in the process. So that's a quick run through of cognitive rehabilitation approaches. I've taken a very pragmatic approach. I haven't, presented all the data or the lack of it to you because there's very little you can do with that information. Whereas with what I've presented, you can go straight away and start, doing cognitive rehab, even if you don't have a team and detailed assessments and specialists around you. Please do, I need to know from you about how the talk needs to be tailored to you, because it's more than 15 years since I have interacted with PGs in India. And so, things have obviously changed quite a lot. So you'll I would request you please to give me feedback on what I need to improve. This, by the way, is a painting from a chap who couldn't read, couldn't write, was very upset that he couldn't even be independent. But he found out from a friend of mine who was a retired pathologist who was coming into the ward to help our patients that he could paint. And he started painting, and this was the last painting he did before he died.
Sir, is there
Yeah,
any role of online gaming in cognitive rehabilitation?
yeah. So it's not yet. I haven't come across a validated one yet. One of my colleagues from CMC Vellore used it for improving fine motor skills. It was part of her MD thesis, which she's published. But I know there's a lot of stuff going on, and sometimes you might just have to use the standard games and other things to help. There's evidence to show that it does help. The challenge is that you need to find out something that they can engage with. So if they have difficulty, for instance, with recognizing faces or recognizing objects, then the quick changing in a computer game may not be suitable, and a slower game may be preferable. If it is that they can't pay attention to one half, then you have to make sure that the screen is on the side which they can pay attention to. So little things like that you have to do. But yes, there's a lot to be done. I mean, that's the other thing. If you are interested in cognitive rehab, there's a ton of research to be done, and you have to make sure that you're comfortable with both quantitative and qualitative methodologies, because a pure quantitative approach has not led us to a place where we can decide what's useful and what's not. Whereas if we start to balance it out and use mixed methodology for our research, we are likely to be able to find an answer. And computer games, there are, again, I feel low-lying fruit, because they will really help us to tie into the patient's interest. And increasingly now, even the older age group is comfortable with mobile phones, so it's not too difficult to have a game on the phone.
Thank you so much, sir. Sir, just a minute. I will take a minute. Sir, can you please elaborate about the instruments to assess cognition in patients with aphasia, any kind of aphasia, because they are not readily available on internet?
So the one I showed you,
Yes, sir.
let me just go back. Are you still able to see my screen?
Yes, sir.
So this one I showed you, this one, Oxford Cognitive Screen,
Yes, sir.
is specifically designed for people who can't communicate.
Okay, sir.
That's the beauty of this screen. And as I said, you just have to write to the team. If you just Google this, there's training videos and everything. But if you do use this, even if a person can't communicate, you will. This is, for example, this page here. They're asked to go from the smallest triangle to the biggest triangle. Just draw lines, and smallest circle to the biggest circle, and then small triangle to small circle to next big triangle to next big circle, sort of thing. So they're asked to do that. So you don't need much language and communication to do this test, and that's the beauty of this test, as against the one which I used to use before, which is the Addenbrook's cognitive screen, which requires there's a lot of language assessments there. This is available freely for use, but you need to make sure that you get the copyright approval from the team.
Thank you so much, sir.